Just have a look, see what you think. It's hospital number.
And face the TV screen. Yeah, that's behind you. A 180 for me, please, sir. And that's it. To begin with again, I'm just going to give the backs of your legs a quick wipe over. So just on the bottom of your calf. 3, 2, 1, off you go. Excellent.
You can come around to the right-hand side. And if you could just take a seat just there, that would be great. Yeah, just that one there would be lovely.
To the stroll on the old long walk on a day and I met a little girl who stopped to talk on a fine soft day and I asked your friend what's fella to do, cause her hair was black and her eyes were blue, and I knew I'd taken the world.
And the sun's coming out for you. Right. Now we're a little bit early. Oh!
Hi Carol, I'm Celia. I spoke to you on the phone and sent you all the patient information.
Yeah.
We screen for patients in clinic. They see the consultant, and if the consultant feels that they're appropriate for the study and they meet the eligibility criteria, we then approach them with regards to the study and let them read all the patient information. After they've had some time to read all through that, if they're happy to consent, we go through and discuss all the study with them so they understand all the study visits, and then we take consent.
My name is Carol Murphy. I've lived in Attleborough since 1976. Before that, I was married and my husband was in the forces, so I've been all over the place.
I'm very glad that you're happy to take part in this.
Yeah, that's no problem.
Okay. Before we do the consent part, which you're happy to do, I just need to check you're still eligible for the study, if that's all right. So can we briefly go through some questions?
Yeah.
Fantastic. So you're coming to have total knee replacement?
Yes.
And it's the first one you've had?
Yes.
Lovely. And you're having it for osteoarthritis?
Yes.
In that knee. Okay, and you're over 18? Once the patient has their operation date, Amanda randomises them to receive either one or the other implant.
Mr McNamara, secretary, can I help you? Here for just over 10 years. Yeah.
Please, Mr McNamara.
No, I worked for Professor Donnell originally, and then when he retired, Professor McNamara took over, so I followed through and was his secretary as well. Capability trial. That's what Mr McNamara is running at the moment. It involves 4 of the consultants. Professor McNamara, Mr Charlie Mann, Mr David Calder and Mr Nish Sharodian. The capability trial is where we're trialling a different implant into the patient's knee. They'll come to the clinic as a normal clinic patient. One of those 4 consultants will then decide whether they feel they're suitable to be entered into the capability trial. Once the patient has consented, I then get involved in the randomisation side of it. So about up to 7 days before the operation date, I will enter the patient's details onto the capability database, which will then choose an implant, whether it chooses the trial implant or whether it chooses the Genesis implant, which is the standard one, is the Genesis implant. I then record that, and the people I let know about what implant the patient's going to be having when they're operated on are the theatre staff, the actual operating surgeon, which is one of the 4, and myself. All the other members of staff are blinded to begin with. So the patient will then have the operation, the chosen implant, the randomised implant will go into the patient. They obviously don't know what implant they've had. Once the operation is done, the patient's notes will come back to me, and what we then do is I will then enter the implant serial numbers that have been used on the implants, whether it's the trial implant or whether it's the Genesis implant. I enter them into the same database, so all the information is there, and then that's my role.
Patient goes through recovery. As normal, we see them just before they go home and have a home diary with exercises for them to do, to record how they're getting on, and different bits of paperwork to see how they feel after their operation. We see them again at 6 to 8 weeks when they have their normal follow-up appointment with a consultant, and we see how they're getting on then. Any complications are recorded after theatre if anything happens, and they also go back to the movement lab and see Jacob there.
I work in the chicken factory at the moment. Prior to that I worked in a chicken factory, and prior to that I did all in Attleborough. So in the, how many years is that, from 1976, quite a number of years, I've always been local and always been employed. My knees, well, my knee, my right one, must have been about 6 years ago. Started getting pain in it, didn't really take a lot of notice, uncomfortable, went to the doctors, and he basically said it's probably arthritis, gave me exercises to do, but unfortunately, like most things, you don't do them like you should do. But gradually got worse, so in the end I went for an x-ray, and they decided it was arthritis. And since then they have tried physiotherapy, because they thought at one time it might also be the muscle at the back of my leg, but it didn't turn out to be that. Did help a bit, but not over the long term. So over the next few years sort of persevered with it, tablets, gel, and had more x-rays, also had an MRI scan because they didn't know if it was something else there as well. Then they decided definitely that it was the bone on bone, and the only thing was to have a full knee replacement.
So once you've had your operation, we'll see you briefly at the Spire to just check how you're getting on before you go home. If there's anything you want to ask about, please ask me as you go through it.
Yep. Okay, yep.
I'm the research nurse that's working on this trial, and I see the patients from pre-screening them when they come into clinic or just before to see if they're possibly eligible for the trial. I then meet with them once they are eligible and go through all the processes except the randomisation, because I don't know which joint they're having, all the way through to the very end at 6 months when we do all their follow-ups. They also have their physio, which patients have for a minimum of 6 weeks, individually and as a group session, to see how they're getting on for their rehabilitation. They have some exercises which they do at home, and that's all done individually depending on how the patient gets along. We then, as part of the trial, do another CT scan after they've had their operation, which Mr McNamara looks at to see if there's any difference with, and I do questionnaires again to see how the patient's getting on, and how they feel they're coping, how their mobility is, has it improved, is it particularly better in some areas, has the pain improved, and again they see Jacob at the movement lab, and he does more measurements to see how they are walking and managing things upstairs.
He discharged her.
So I've got one copy to give to you and one copy that I'll keep in your medical notes.
Okay.
And that's it for today.
Mm-hmm.
We'll be in touch with you for the movement lab as soon as we know when your operation date is, and I'll be back in touch with you just before.
Okay.
That's all right.
Yep.
Okay.
Yep, fine, thank you, Sheila.
I came to Norwich about 5 years ago, and before that I was the chief exec of a number of large teaching hospitals in London. So I've seen, who are very research active, so I've seen this in action, and I wanted to bring some of that into Norwich. Doing research enables new technologies to be found, new techniques, new drugs to be tested, and this will help patients in the medium and long term. But the really important thing, I think, for local patients is that I know that from my own knowledge of the NHS and internationally, it's known that those patients who are on trials do better than patients who are not on trials, and therefore there is an immediate advantage and benefit for our local patients as of now, not having to wait for years in advance. So those are the two reasons why I believe that it's really important that in the hospital that we really push research, and I'm delighted to acknowledge that we have so many active clinicians, doctors, nurses, physiotherapists, pharmacists. They're all engaged in research, and that's something I want to encourage.
I'm sorry I didn't see you personally in clinic, but my registrar and, if you like, it's all about them. It's all about the research. It's all about the orthopaedics. It's all about the people.
Could I clarify that date is still correct that you sent through Estelle, that no-cost extension?
062 is the one for the 21st of September.
Yeah, and there was somebody before, but that's the patient that I think
Yes.
they came with.
I've got a slight dropping of the general abdominal contents, but I can't remember why. Participant burnt themselves on an exhaust pipe before the operation. There was a patient that was cancelled post-randomisation, and presumably they've had their surgery now, haven't they?
Probably no 4 that I can think definitely lateral.
And they will have fallen into 2 groups, and I don't know which group he does in the room. So maybe we could also have a look at those.
Yeah, for sure. I can tell you Ron isn't in the embedded qual, so he'll miss out. The army, the military person.
Yeah.
Angus.
He is in the embedded qual.
Yeah.
51?
You got that on there for me.
I know she is.
We've got more room for healthy people because it's better to get them in whilst we're not busy.
Yeah.
Whilst we can invite the patients to the physio, they might not be able to attend.
Yeah.
It's going to be tricky to match up where people weren't able to attend or where there's a missing CRF because we haven't seen them yet. But Celia has got a very robust plan.
Because they chose to have their physio up at Cromer, and because North Norfolk, they're contracted differently for physio, so it affects NNUH patients.
Fine, okay.
What was the number of the one that you didn't have a date on? Is it the 082?
Don't know off the top of my head.
Yeah, 082. Now the 22nd of November.
Okay.
The patient that I've consented today, their surgery's not going to be till November, December, just so that you have aware.
We just Spire is so full. Everybody's struggling to get this.
Good morning, everybody. We'll start with an update on where we're at this morning. We've got 28 inpatients, 1 patient in the ERU, and 17 day cases coming in. There's no staffing issues across any of the areas.
So we've got our results in for last month recently, and we've seen some really good progress with some key areas. So Ali, you were saying something about the cleanliness of the hospital and areas where we can look at that.
Yes, well, we've got the place audit coming up again next month, so we're just planning sort of the preparation for that.
We just need to have a bit discussion how we can improve.
And we have informed the patients of the action we've taken thanks to their comments.
And they've gone to print now, so they'll be in the hospital in the next week. So patients will start getting those new brochures with the, bit of clarity around the information there.
Hello, my name's Ron. I had a replacement knee operation on my right knee on the 2nd of July, so we're 3 weeks into that at the moment. I'd had a left knee replacement about 2 years ago, so I knew what to expect. This is proceeding just as I expected, a little bit of swelling, but the mobility's there, and this is my second physiotherapy visit, which I found to be very helpful.
Most people who've had a new knee have osteoarthritis, and the symptoms generally get worse from 55, 60 onwards. So, I think you're doing very well. 125 3 weeks down the line is quite unusual. You don't want to be in a bath soaking the wound in a bath really yet, because it's not quite got that new fresh layer of skin.
We don't have a bath in the house.
Excellent. But when you get that new layer of fresh skin, which you can see is almost there on the top, then you can potentially do things like that and go swimming. To say, have they got better quicker than normal, about the same, or they're slower than normal? And then the outcome from that is that we feed back to the researchers.
We're going to have an interview, a semi-structured one. I've got some questions about mood, pain. Oops. Perfect. Anterior 33, lateral 48th. Perfect. Turn around for me, please. How far can you walk at the moment, do you think?
Well, it's really hard to say because I don't do it all in one stage, you know. But comfortably, I mean, say the amount, I don't know how much we walked up and down there, but was that miles?
That was on the limit, was it?
Probably, yeah, in one go, without sitting down.
Right, very few these fish.
Morning, how are you?
All right, thank you.
So today we're doing a total knee replacement. Mrs. Murphy's very kindly agreed to be part of our trial, so she doesn't know which implant she's going to be having. The theatre staff I've already seen and they're ready to go with the implant that's been selected for her, and we've just run through the final bit of consent. At the same time, that slight bend that you've got coming on there because you're wearing out the inside more gently gets corrected over. And then we also give you a new kneecap at the same time, which just helps basically some of the kneecap symptoms as well. Okay? Whole thing takes an hour or so. You'll obviously see the anaesthetist, they've run through things before. And then after that, we basically get you back into recovery, back up here, and then go from there.
Okay,
right?
yeah.
Still want to do it?
Oh, yes.
Fine, right, good. May I have a quick look, is that alright? Do you mind rolling up your trousers? Happy to this side? Yeah, fine. You can put an arrow there and there. That's not where I'm making the hole. They're just, I can check which side I'm doing. Yeah, absolutely. So basically, as we talked about, cut down there, okay? And borrow those. Put a little arrow there as well.
Well, Scotland, like most countries across the developed world, has a deficit.
Any questions?
Fine.
Let's get on with it.
Thank you.
Alright. Cheers.
Thank you.
Cheers, bye.
See you later.
The former First Lady, Senator and Secretary of State.
So, when was the last time you've eaten anything?
About 8 o'clock last night.
Just stick that there, it's just easy for you to get hold of.
Right.
Okay?
Yeah.
Brilliant. Would you like me to leave your door open or close it?
Hi Carol, my name's Heidi. Hello. I'm going to take you down. When's the last time you had food and drink? The surgeon, and that's your signature?
Yep.
Lovely. Okay. And did he give you a mark on your knee?
Yes, I've got some
Can I have
marks.
a look at it, please?
There's one up there.
Lovely.
There's one down. We're going, yes, at last.
Thanks.
Floor 2.
See you later.
See ya. Right, you'll pass go, parents. Just got to follow the corridor around there. Are you warm enough? Yes, yeah.
The burning thing, James. The reason being is I can then strip this medially. Great. Stitches, please. Scissors, please. Medially. Thank you. Good job. Thanks a lot.
All the best, Carol.
Thank you very much.
There is some water there, and I'm sure you'll have some gin later. I'll come join you. Thank you, dear. Thank you.
Thank you.
Lovely, thank you. Check her blood pressure. I'm going to let her sleep. Rest, and for the time being it's just resting and recovering from the anaesthetic. And when your legs are woken up a little bit later on, we'll get you up and standing and physios will do some work with you.
So orthopaedics is traditionally about improving quality of life. If you look at our population as a country and also of our population here in Norwich, there are an increasing number of people who are either retired or over the age of 65. Although age doesn't cause arthritis, arthritis often goes hand in hand with age. When you look at outcomes of knee and hip replacements, which are incredibly common operations both in this country but also in many other countries in the world, they are successful operations. 85% of patients who have total knee replacements are satisfied with the results. That is a good thing. However, that does mean that 15% of them are not satisfied.
The aim of this research is to look at those patients who may be dissatisfied with those results and see, can we actually do something about them to improve the outcomes of the population as a whole? This is important for quality of life, which is one of the aims of orthopaedics, to improve the quality of life of those people who may well be struggling with the pain and disability of arthritis, and ultimately to try and keep them active for longer.
Come in.
Hello. Morning. How are you doing?
Oh, thank you.
How's the night?
Not too bad, except for the bleeper.
Except for that thing, yeah. I know. Keeps you awake all night. Yeah, sorry about that.
No, I've got some earplugs, so it was alright.
Can I have a quick look? Is that
Yeah,
alright?
of course you can.
Fine. Good. So dressings are nice and dry, aren't they?
Mm-hmm.
How's the pain? All right,
So it's more like an ache more than a pain.
Okay, fine. Can you feel me touching you there and there?
Yes.
Feel the same?
Yeah.
There and there?
Yeah. Yeah.
Good. Can you just pull your toes up for me, please? Fine. Good. Any pain under here?
No.
Feel the same both sides?
Yeah.
Good. Just push down hard for me? Good. Fine. Alright, well, I'll leave you to it, but the physios are going to be around in a bit.
Okay.
And they'll start getting you up and getting you on your vessel frame and then crutches. And then we'll go from there.
Okay,
We'll get a
thank
blood
you.
test later, make sure everything's okay,
Mhm.
and then I'll catch up with you later.
Okay.
Alright?
Yeah, no problem.
Any questions?
No. Leg was no problem, no pain. I find it easier to put it on the side than keep it dead straight. But no, apart from the buzzer, I slept fine.
I'm going to do one more. Squash, up and back down. Get the control going up and down. Then we can add on more and add on the holds.
Must be free.
That's the hard one. Okay. So they're your 4 exercises we get you doing for this first week and building up your walking as is comfortable. We then get you back about 7 to 10 days post-op. This allows us to check your calf still okay, so again, risk for DVTs, check your wounds all okay. Then we can start to progress your exercises to get your knee stronger. Make sure it's bending well so the scar tissue's not getting tight. And as well, obviously progress you down off your crutches when you're ready. Do you want to bring your legs around towards me? So just have a little sit, see how your head feels. Okay? You feel dizzy or sick at all? Quite normal with the anaesthetics. Has a little bit of effect on the blood pressure. That, in a way, will gauge how much we do. You're going to have one hand on there, one hand back, gently slide that leg forwards. Good. You can leave that leg back as you sit.
Yeah.
It will make you bend your knee more, which is fine. Sliding it forward makes it more comfortable.
Yeah.
Okay. Now you're on your slide sheet, so you're going to wiggle your bottom straight back towards Natal. If you need a bit of help with this leg, you can always hook your good one underneath.
Yeah,
Just
okay.
helps take the weight of it. Keep going a bit further. You want to get as much of your legs on the bed as you can.
Okay.
Makes it easier when you then need to pivot around. If you do want a ice pack at any point, okay, it will help bring down the swelling.
Yeah.
Okay. It helps calm the inflammation around that
Can
incision
I use it?
site.
I've got some of those at home. Can I use them?
Yes, definitely use at
ones that
home.
wrap around.
Absolutely. What we say is a maximum of 20 minutes. Don't want any risk of any ice burns happening. And make sure it's wrapped in a pillowcase or a tea towel.
Oh, it's got its
Again,
own- it's got its own
has it got a nice coating?
Yeah.
Excellent. The one place we'd say never pop any ice is at the back of the knee. There's some nerves and blood vessels there that haven't got much protection from muscles. We don't want to irritate those. So never at the back of your knee.
If a year down the line, you might see people who've not had some physiotherapy compared to some people who've had some physiotherapy. You might not see a huge change. But the first 3 months, I would suggest, you can improve people's quality of life dramatically.
Carol Murphy!
Hello, hello.
Hello, Mr. McNamara, all right?
How are you?
Okay,
Very nice
fine,
to see
thank
you. Very nice to see you.
So just carry on with the painkillers, all right? It'll carry on settling down. Keep working your bend with the physio. The painkillers will let you carry on with the physio, okay? So don't stop them too soon. As we get that last bit of bend, then we can stop them as the knee just carries on settling down. The swelling will gradually go away.
Was it worth doing?
Mm-hmm.
Fine. Good. Would you go through it again?
Oh, I don't know about that. I was just one don't come out in sympathy with it.
Yeah,
Every time I've noticed in the last couple of weeks, all of a sudden my leg goes dead, this one, and I thought, oh, is it coming out in sympathy with that one, you know?
Keep an eye on it.
Yeah.
Keep an eye on
But,
Fine. Well, thank you. As I said, thank you very much indeed for taking part in the trial. We're still following everybody up. So once I'm still blinded, so I can't tell you what you have.
I know.
As you know.
As I know.
And as soon as I'm allowed to do that, then somebody independent from UEA will let you know.
All right.
And then they will have analysed the results and we'll let you know the results. Okay, good. Really nice to see you.
Thank you very much. Okay.
So as you've just seen, that was Carol. She's now about 6 weeks following her knee replacement. She's still progressing well. She's having physiotherapy. She stopped her painkillers, which it means that she gets some discomfort when she's been walking for periods of time. As you can see, as part of the trial, she's been over to the movement lab over at UEA and she's been put through her paces there, which is very kind. Now we just need to make sure that she carries on working on her range of movement. She's been to physiotherapy already. She's going back to physiotherapy next week. We've talked about the exercises that we'd like her to carry on doing, and I'll see her in a few weeks' time to make sure she carries on progressing.
Got full straightening of their knee. Just say, "Hi Pete, you've forgotten me," something like that, so that will come and look at you. That's really important because that looks great. Cycling, again, you've got to have at least 105 degrees. If anyone's not got that, please let me know, or just don't go on it. If you need the seat adjusted, because that's really important, we get that right. Again, just raise it. Cross trainer, everyone knows what they're doing on that one, it's fairly standard. You got the stopwatch?
I'm ready.
I was just looking at the stopwatch, brilliant. So if everyone is ready.
Happy everybody?
Yeah.
Off you go.
I'm a physiotherapist, I've qualified 20 years, almost to the day. I've been working here for the last 15 years. My background is seeing lots of people in outpatients and looking after people post-operatively, so that's a lot of what we do here, inpatient care and then post-operative care to ensure that people recover as well as they possibly can after bad surgery. In the Norfolk region, we have an awful lot of rural dwelling people, so farmers, runners, tree surgeons, firemen, and as that characteristic, it can be, most of the time people will be above the age of 65, and then there's a few outliers which are relatively unusual, but if someone's had a car accident, but as is across the whole board, you've got very large people, who very small people, people generally of different shapes and sizes can have a new knee replacement. That's never kind of a block. But again, all of these things you have to tackle or monitor according to how your knee is coping. If it's getting more swollen, more painful, then you need to make sure that that's not.
If you start getting swollen, so at the end of the day, that's telling you to take a rest, is it?
Yeah, or even after a certain action. If you just bring your bottom against there, that's lovely. Down flat, lift your heel off the bed. 1,000, 2,000, and then you hold that for 3 to 5 seconds and then relax. Hold down that one. Try and get as straight as you possibly can. And then relax down, good, and then try that just to have interest on this one. You've got a very good knee bend. When you know you can go far enough, you can go all the way around. You're doing extraordinarily well, so that's very good indeed. Key thing if you're going to do anything additional exercise-wise, such as cycling, and if you've got your own static bike, is trying to not overdo it in the early stages.
Right, yeah, okay.
I kind of think about it as if I was going to do a marathon, the first run I did wouldn't be 20 miles.
No.
So I'd do a mile or two and then I'd see how I was and then build it over months.
Yeah.
In a similar way, with the new knee, you need to build it up over weeks and months.
5 minutes on a Monday, see how I feel on the Tuesday, and then just gradually take it.
Yeah, I wouldn't progress more than like a minute or two each day.
Okay. Basically North Country until I got married, early 20s, and then just travelled around the country with jobs. And despite spending a fortune, as you can hear on elocution lessons, I still have my northern accent. My professional work was primarily desk-related jobs with a fair amount of walking and what have you. And it was only when I realised that I could no longer chase my 4-year-old granddaughter around the garden as fast as I could that it was getting uncomfortable. I went to the doc and he said, "Oh well, we'll just send you off for an x-ray or what have you." When it came back, he said, "Well, you may be amused to learn on both your knees the bearing is worn away and it's basically bone on bone." So I went to see Mr McNamara and he said, yeah, which is the worst knee? I said, is that one? He said, yeah, but your muscle's very weak. Go and get yourself an exercise bike, do a year's exercise and come back and I'll put you back, come back in a year. So I came back in a year and they did this week knee. And that went perfect, yeah. And then 2 years later, I've come round on the queue and he's done this one. And he's obviously remembered how to do it because this one's just as good as that one as far as I can see. I think there was a bit more work to do on this one, it was a bit older. I can now move both these legs as far as I could before I had the operation. And in fact, now I've had the operation, it doesn't hurt when I move them either, so that's the improvement. So I think it really was just listen to what they say about doing your exercises, get to where it hurts, and then keep going, you know, until you start to sweat.
So, calf stretch here. Yeah. The key components are having your toes turned in.
Ah.
So bend that front leg, and there you go.
Oh, I see, yeah. It pulls it automatically.
Trials in research are extremely important. They allow us to understand not just how things work, but why they work, and so that we can use that information to then either lead to changes in public policy, health policy, or further trials. The public play a really important role in that, both in helping us to design the projects and monitor them to make sure that they are in the best interests of the public, but also as participants. We can't study a specific disease without individuals who are suffering or have that disease or habilitation.
We're going to start out now with a bunch of measurements which we got from you last time. No, I'm not going to bother. This one here for me, Ron. If you just stand up on there for me, facing forwards.
What was it last time?
Height-wise.
I think there is one thing that we have worked on quite hard in the last year, maybe 2 years, to try and help prepare people as much as possible in our pre-assessment, so we can assess their social situation and their home environment, so we can try and make it as easy as possible before they actually come to the hospital. But even while they're here on the wards and in aftercare and physiotherapy, we're trying to address those psychological concerns or worries, and a lot of the time we call them barriers to their recovery. If people are very anxious about trying to bend the knee because they've got fears that it's going to split open, which in a way sounds logical, but it doesn't ever happen, they don't bend the knee. So we try and address those very regularly occurring concerns early on to make sure that they know that it's not going to split open. So it's fear of moving it, fear of pain, but also trying to get over the concerns that people have because they don't sleep very well at night. For the first 4 weeks, 5 weeks, the night pain is a significant issue. On a 0 to 10 scale, what would you say that would be?
It's just an annoying thing, probably 1 or 2.
1 to 2, all right, okay.
It's just, I only mention it because it is not the usual soreness and aching that you'd expect, it's just something.
Semi-unblinding at participant completion. Celia spoke to me about this. I didn't have any problems with it. Did she discuss it with Alan, or would you wait till she comes back?
The final 2 patients, the 6-month follow-up wouldn't have been completed until June 2020, which would have left a very short period of time to analyse and write up the trial paper. And we thought that we were going to wait until we approached Smith & Nephew until all the patients had been operated upon.
To me, from a patient's point of view, just continually stress, because the physiotherapists are fierce people, you know, they knock you around horrible. But they do say, they did tell us, you know, you've got a certain amount of time to make sure that the flexibility of this limb works, particularly the kind of backward bend your limb, so do your exercises so you'll never get it fully mobile. I just think that when this is written up, maybe quite a deal of attention needs to be paid to that, as well as physical implant. That's my...
I tell you what we can do, because it is I completely agree with everything you said. I think it's a really powerful thing. We can explore it and really flag it up for the qualitative researchers. So, you know, as a theme, you know, one of the members of the team and then actually the team in general feel that actually the rehabilitation is important, and exploring that with the qualitative work might be something that we can do, because I think you're right, we won't have enough numbers to be able to show much. We might be able to get an idea, But what we're doing is we're almost doing exploratory analyses to work out if there's a hypothesis here, so that we can then, my idea is to then go and say, look, this seems to be something going on, maybe we should explore this a bit further. So, both in the quantitative and the qualitative data, we can get some traction to be able to take it forwards, because I completely agree with everything you said.
And, I still think that could be an issue unless you're able to. But I don't know if the sample size is big enough to differentiate between people who fully engage with physiotherapy and those who haven't, and make any kind of comparisons between those two groups. Probably you haven't got enough people to do that. I mean, I would be interested to know if what the difference is between those who have engaged fully with physiotherapy and those who haven't, and differences inside those two groups. I don't know if we've got enough people to do that.
Alan, what do you think? Probably not in any meaningful way. I don't know exactly what the compliance with use of therapy will be at this stage yet either. So, Toby will have more experience in that.
Yeah, no, I don't think we'll have enough. We might at best get a signal if there's some trend of a difference, but I don't think we'll have anything really meaningful. The other question is there any planned case analysis where we've actually kind of classified a priori what adherence or compliance would be? And is that worth considering at this stage while we're doing the SAP?
Well, it's compliant with the intervention, which is a knee replacement.
Yeah, rather than the follow-up.
Yeah.
Okay.
So, no.
No. Okay. No.
Unless you want to include people not getting knee in.
No. I suppose it's just if we felt that the compliance to patients' post-operative outcomes, post-operative care.
They found calcium pyrophosphate, which is otherwise known as pseudo-gout. So essentially it presents like gout, but it is a different pathology. But you end up with hot, swollen joints, those kind of things. Because infection couldn't have been ruled out, and actually she wasn't very well, which gout and pseudo-gout and infection can do this whole thing. She was operated on clinically. The knee was washed out to reduce the burden and the load, and all the correct samples got sent. And actually a DARE, which is the debridement and implant retention, so you take out the middle lozenge, the plastic lozenge, you send that off for culture, and then you take all of the potentially infected tissue around it, re-implant the same size lozenge, and then get the patient going on that, but treat them as expectantly as though they've got an infection. There's been no growth on the organism from the cultures. So I think it is calcium pyrophosphate. I don't think it's a true infection, but it does count as a revision.
All our participants, we try to see 6 to 8 weeks. We have a window that we fit them in, so Ron's right at the end of that window. But he's come in today. He's done the same assessments that we would have done at baseline, and we've repeated them then today just to see how things have changed. With some of the assessments, we're not necessarily expecting him to have gone forward. 137. And then nice and straight for me, please. Some things he would hopefully have found a bit easier, but from what we've seen, he's doing very well. That's for our computer system. So what we'll do, we're going to pop markers on the outside of the knees. Right. And if we use a device like this, we'll be able to find the joint centre. Did you have any issues with our markers last time? In terms of the tape, were you okay with those?
Yeah.
Perfect. We wouldn't expect you to. We'd just like to be sure. So what we're going to do next, we're going to pop on a bunch of markers. These are for use with our camera system, which is around the outside of the room. These are nothing but reflective balls. Pop those on your lower body so that we can track you as you move along the room. Phew, Ron, I need to get to the backs of your legs, so could you just stand up for me? EMG sensors on those, and then the backs of your thighs as well. Just a good clean swab.
So I'm going to start off with your right leg first. Okay, and I'm going to take you through a series of movements. Okay. Extend your leg out as far as you're going, tense the muscle there, and again you can see your muscles firing there, it's a good signal. Okay, and down for me. Next exercise, if you can just go up onto your toes, and again just tense that, again, see what's lunge, yeah. Next one, if you can just tense, put your foot up like so.
And all we're going to do in a second is just take a static recording of you. That's acceptable, I think it's the bend in the knee. And turn with the pelvis. We can put our little stick figure on and follow you around the room. Excellent. Okay, we'll just jot that down. 10, 10, 10. What I need you to do now is move on to your left side for me. So if you centre your left foot on the middle of those lines for me. Good.
3, 2, 1, off you go. Three, two, one, off you go.
This machine is called an isokinetic dynamometer. We're going to strap Ron's leg on his operated side and his non-operated side, so we'll get a good picture of the strength in the leg and also the strength between legs to see where any discrepancies lies. The cameras are really good for showing us in a lot of detail how he's moving, but this just gives us a lot more information in terms of, well, is it due to a weakness in a particular muscle in how that's reacting? So that's what this machine will pick up. Off you go. Pull, pull, pull. That's much more like it. Good. 65, well done. So today we saw Ron, who is 8 weeks to the day post-op. There is something to it, but we'll go through it at 6 months when we have all your data together. We can have a bit more sit-down chat and see where you're at and go through things like that.
I don't do early mornings, and we didn't have to get to the hospital, I think I recall, till about 11 o'clock. And I was shown to my room. Very nice, because again, I'm very mean, and I don't, now that I'm retired, I don't pay into a private health care insurance. So therefore, the fact that I could have my knee done at Spire without having to pay for it was really, really very nice. I had to teach computer studies, which I didn't enjoy, and it was the very, very early days of computing. Once I'd retired, our holidays weren't just in France, our holidays were anywhere. You know, it is that social aspect, and I'm sure when I hit the ball, I'm not even sure that I shall hit it very far. Oh, you can see I've not played for weeks. How do I feel? My knee is absolutely, there is no problem with my knee, but today is a good day. My back isn't hurting. It's just that I'm not particularly loose at the moment. If I'd played the first 6 holes, I would be a lot looser. I think I'm now going to have to move us on, because I think the guys who were coming down behind are actually shortly going to catch us up, set their game. But nobody's about to hit it. Good morning. Morning. Hello. My name is Anne, and I think I came to having my knee done because, like most people, as you get older, I thought to get arthritis, etc. and so forth. And although I've never had a background in sport, I actually took up sport when I retired, and I started to play golf. Now, I don't play golf very well, but at the same time, I enjoy the exercise, I am keen to do the exercise, and I wanted to keep fit. So then, when my knee started to get a bit dodgy, and I thought, this is arthritis, I went to the doctor. They sent me to the hospital, and they looked at me and they said, oh no, you're perfectly fit, go away. We'll see you again next year. So the following year I came back, and which was in 2019, and by that time I was having to use a stick, which I didn't like, but I was having to use it because the knee was quite painful. So, I mean to say, what more can I say? The interesting thing was, I went to see the consultant, and he said to me, well, we could offer you a place. And then I went back to the golf club one day, and I found a lady who had had both knees done, and she was playing perfect golf. This lady here, I spoke to you last week. Joy, come across here, please. This lady is the lady that encouraged me to have my knees done, because if she wanted to be indecent, she would now show you both her knees that she's had done. And it was her recommendation that made me go ahead. So I've got Joy to thank. To see this is because when I did it, I'm part of the survey, a research survey, because they were testing a new knee or an old knee. Well, I don't know which one I had, but this is an ongoing part of the survey. And I looked, and she pulled up her trousers and she showed me the scars on both knees, and I thought to myself, well, if she can have it done, I think I might just as well have a go and try. So that was it, and exactly 1 year ago today, I got my new knee. So that's a coincidence. Since then, my knee has been absolutely perfect. When I saw the consultant, he said to me, I can't guarantee that we shall get the bend back to more than 90 degrees. And I said, I think we can. And of course, because I'm very, very competitive in nature, because I play bridge and I've always been very competitive, I was absolutely determined I was going to get the bend back to much more than 90 degrees. And so that was really my challenge. I mean, to say, when I was very, very young, my father was so ambitious for me. It was really quite a strain. I performed quite well in school, but he always wanted me to do better. And, you know, I mean, to say, OK, I was going to be nothing other than a doctor. Well, a doctor would have been the last thing I would have ever been, because I'm so squeamish. That was it. He set my targets, because while I have accepted I can't play golf, still doesn't make me uncompetitive. Stay.
Have you got a minute? I can't get sound through this amp, and I don't understand why. I say, good job it's not a gig.
Yes.
This is Pam.
Hi.
I've known lots of people who've had the knee op, and most of them have been successful. Some haven't, but most have. Yes, we do mostly full dances, and we do concerts. Concerts are something I don't really enjoy. I much prefer doing a full dance where the audience is dancing around, people join in, that sort of thing. And mostly in village halls where there's a country music club. The gear is not lightweight. It's surprising how much you have to lift about and so on. So there was. Yeah, at times I really struggled. Quite severe pain. And then I went to physio, and I was virtually, after maybe a fortnight, 3 weeks of doing that religiously, I was virtually pain-free for about 2 years. So maybe you should push the physio side really beyond even what I did, and I thought I did. I thought I was quite dedicated to it. So I mean, if you can push it as much as you can, that I would recommend anyone to do. And from what the surgeon said, that did need to be done. He said it was a mess in there. That's what he said. Yeah. So nothing was discussed about the other knee. Hopefully that'll last me out. Well, I'm John Neal. I go as the stage name Johnny Neal, and I've been around a long while, as you can probably see. And where we are now is in my music room, and dedicated to just that. I spend a lot of hours out here, and we live in a village deep in the country in Suffolk. Ah, Suffolk I went. We sometimes do, the ideal situation for us is to mix the whole thing up. And for the generation, anything from 50 upwards, really. But the youngsters like the rock and roll. Here we go now. They still like the rock and roll. I've been doing that all my life. I've done other things as well, had businesses and so on, as well as, but the music has always continued. If I'd had the chance, then I would have liked to have learnt the piano. At that time, no one really mentioned keyboards. I'm quite ancient, so at that time you didn't have the keyboards available. They are absolutely wonderful instruments, and I think my time again I would have learnt that, and I would have learnt earlier if I'd had the chance. Yeah. But I went to, as I say, I served my apprenticeship, and I was on really good money as a tradesman. But I thought, I'm going to be in this factory all my life, and it was interfering with my music, because I might have finished and packed up the gear perhaps about 1 or 2 o'clock in the morning some places, and then I'd got to be up again to get to work at 8 o'clock in the morning, and sometimes worse than that, maybe 5 o'clock in the morning. It depends on the shift. When it got so that they wanted me to go on permanent shift work, alternate shifts, which would have affected the bookings and so on, I then decided then I'd get out and I'd go self-employed, doing something with the music, because I had a young family, and that's what I did. I suppose in the circumstances, I wouldn't have had a real choice to do it any other way. I could have said, okay, I got a young family, I can't afford to do the music, I'll just concentrate on business or whatever, you know. But I did love the music, and it brought in reasonable money at that time. Yeah. So I mean, if you want to be rich, you don't become a musician. Yeah.
I have heart problems, consequently I can't lift the real heavy stuff. But we got to the stage at the end of the night, if we had to pack up, John had difficulty trying to carry the stuff that he wouldn't let me carry, and we got to the point that
vicious circle, really.
Yeah, if we couldn't stay overnight, we would have had to stop.
Yeah.
And it's great to be able to say at our age we're still playing.
Well, that's right.
Still getting gigs. People phone up, which is good, but people phone.
That's why you got to do it while you're still young, you see.
Took a stroll on the old long walk on a day and I met a little girl and stopped to talk on a fine soft day and I asked you, friend, what's fella to do? Cause her hair was black and her eyes were blue, and I knew I'd been, I'd taken the world round the Salt Hill Pop with a Galway girl. We were halfway there when the rain came down on a day and she asked me up to a flat downtown on a fine soft day and I asked you, friend, what's a fella to do?
wasn't a rich kid, so I didn't have a guitar.
35 years.
35 years.
Yeah,
We've been friends way over that. Pam's husband, Pete, and Pam and me and Jane used to always holiday together, and I think I've got a golden knee.
It's Lorenzo.
Lorenzo?
Yes, I'm back.
You're back, that's great. Lorenzo, we were just saying, you know Carol, who was filmed as part of the research study?
We're due to see her Friday the 9th of October, Lorenzo, and because you followed her all the way through, we thought it might be nice if you were there for her final one as well.
Brilliant. Can you give us, obviously not now unless you've got them, but rough numbers of the kind of the gender distribution and also the categories that the rough age categories, so we know roughly who to target? Because
okay.
The spouses of the people who are coming for assessments for lower limb surgery are often a similar age and may or may not be affected. And if they're not affected, then they're often very keen to be involved. Is that not true?
I think we need to wait for the normative data. It's a separate study. It's not going to lock in the database for the trial.
No, exactly. It needs to be separate. The long-term follow-up biomechanical data should be separate.
There was an issue in the last minutes about the accessibility or privacy of the raw data, and what was Smith and Nephew's view on that? And I don't know if there's been a conclusion on that.
The original agreement that we've got with Smith and Nephew says that the sponsor, which is the NNM, and the CIs have ownership of the data.
Consumer patient point of view, I think most participants, although I can't speak for them, would feel that it was good that what they were doing was as widely available as possible and wasn't kind of locked into one company.
How are you getting on with stairs?
Stairs at home are a bit steeper, have a greater rise than the test that they give you at the knee clinic.
2 steps, 1, 2, and then climb the stairs however you like. So you can go one at a time, you can go one over the other, and the handles are there for you to use. We'll say turn around, pop your toes over the top step, and then wait for David to say go down the stairs. You'll be quicker than the computer is at resetting yourself. So once the computer's ready, he'll then tell you to go down.
3, 2, 1, off you go.
Lovely, Ron. Turn around for me then, please, and pop your toes over the top step, and then wait for David to count you back down again.
I've contacted and had correspondence with all 9 outstanding capability participants. 8 of the 9 are coming back. 1 of the 9 has said they work away from Norwich now and do not wish to attend. That's the footballer. So he's now, but everyone else is booked in. We've got 3 next week, 3 the following week, and the rest filter in October when they're available. I'm glad Lorenzo's actually here because we've got the one person that you followed for the movement lab coming in. Are you interested in having that visit filmed?
Sorry? It's in the box. So, this is the Y balance again, obviously named because it looks like a Y on the floor. And this measures your functional balance. We obviously already looked at your static balance, standing on 1 leg, standing on 2 legs. So it's not an easy assessment, so we'll take it easy. And again, we'll just do what you're comfortable doing. So, 1 foot on the box, pull these in, because I'm not that good. Again, balance assessment, everyone in the same position, hands on hips. With 1 foot, you push that box as far forward as you can, but only on the vertical edge of this platform, as far as you can. No kicking it off the end and no pushing it until you fall off. You have to make some effort to come back this way. Once you've done that, get yourself set. And the hardest one is that one there, round the back, out that way as far as you can. We'll take it easy. You were good at this last time. I had a look at your numbers. You were quite all right. We're going on the right, which is the op leg. So if you just square up with the line for me, that's it. And then pop your hands on your hips and we run as well. When you're ready with your left foot, or just on that flat edge of the box there if you can, as far forward as you can get it. Nice and steady. Just take your time. Good, that's absolutely fine.
Not allowed to kick it.
Well, yeah, exactly. We'll do it one more time.
Yeah.
Nice and steady for me. Good. Oh, that was a bit of a kick again. That's good. Keep controlled. Gonna need to get you to do that again, I'm afraid. Yeah. Lovely. Yeah, very good. Step off for me for a second, Ron, whilst I just shout these numbers. So we've got anterior 39, lateral 72, and medial 74.
We are in the middle of a global pandemic of COVID-19. The UK has been in lockdown for just over 3 weeks now, and that has obviously changed everybody's lives. Within the hospital, which is where we are at the moment, we've very much moved away from elective practice. We're doing trauma. We are running minors within accidents and emergency, and anything that is essentially not life or limb threatening has been postponed. In terms of capability study, things were progressing really quite nicely. We'd fortunately operated on all of the patients. All the patients had been followed up, and we had now 9 patients who were awaiting their 6-month review at the UEA to have their movement lab assessment, and they should be coming up in the next 6 weeks or so.
So here you've seen that we've followed 4 patients who've had knee replacements. They come from different walks of life, they have different hobbies, they have different aspirations, but they've all done very well, and we are obviously pleased about that. However, this research goes further than just Norfolk and Norwich and the Norfolk population. The outcomes of this research can impact upon not only the UK but also globally within the populations, as we're part of a global community that's hoping to improve patient outcomes everywhere.